Go ahead.
Okay, hi, I'm Scott Selling from the Community Health Center Association in Connecticut. I'm the Director of Clinical Quality, and I'm talking today about a project called, we're really helping to implement access and redesign in community health centers. But the concept is that we studied a number of sites that have already implemented access redesign and realized that there's some that were successful and some that weren't. And so our concept was, I was lucky enough to have a dental student and a medical student from the University of Connecticut School of Dentistry and Medicine to help me reevaluate why some centers were successful in implementing this change and why others weren't. And so we realized that the successful centers followed a certain flow. And so this flow is diagrammed right here in our poster. And so now what we're doing is we're going back to the centers that haven't been successful in implementing, and I'm actually doing some clinical microsystem coaching. So I'm taking this approach and I'm working with those centers, and I'm doing 4 centers in a 6-month period, taking an hour, working with their leadership teams and their access redesign teams, providing that clinical microsystem coaching, making sure we're following through these steps, this flow, doing data collection, needs assessments, identifying individual goals, and then doing small PDSA cycles, and then doing patient education, because again, patients are a very important partner in this process, and making sure they're educated on the open access policies, and also making sure that that we do needs assessments so they can understand, and we can understand from them, reasons for no-show rates, which are very high in the community health center world, reasons for why patients might not be following certain clinical protocols. So we really look at an important partnership between the patients and the providers. And the other important piece is that we're creating vertical teams. So we're making sure that providers, schedulers, IT folks, medical assistants are all part of these clinical teams and helping us make these decisions, because a lot of the bottlenecks in our patient flow can be identified not just by providers, but by the other teams that provide services to the patients. And I think one of the neat things is through this process and through this partnership initially with the University of Connecticut School of Medicine and School of Dentistry, is that we're now working with something called the Urban Service Track, which is a program that the University of Connecticut is implementing through their School of Pharmacy, Dentistry, Nursing, and Medicine. And so those students, those first-year students, are all taking classes together, so they're learning to integrate and be a collaborative work environment between those different disciplines. And now we're going to be working to get those students opportunities to work in community health centers. And we'll be training the mentors and the preceptors to make sure that that's a very enriching experience that they're having.
Great. My first question is, what do you see as some of the largest bottlenecks in this process?
Well, I think if you look across the community healthcare system, the no-show rates are huge. So we've got 30% on average no-show rates. So some centers, to compensate, are now booking double booking patients. And so now a provider might have 20 clinical appointments a day. They're booked for 40 patients, and 15 show up. So there's a lot of clinical supply and demand issues involved in that. So we're really looking at patient education so they can understand, the patients can understand the implication of not showing up. But we're also working with the medical assistants who in many cases know the patients better, so they know that this patient X might be getting a transportation with their nephew or niece, and so we need to make sure maybe schedule that nephew or niece at the same time that this other patient comes in, so they can coordinate. There's a lot of issues that the community health center patients face, transportation being one, and really the lack of freedom to schedule their own days. And so we're really looking at all those impacts. We also are looking at panel sizes, because currently there's no real loyalty between the patient and provider, because patients come in, they might see one provider one day, another provider another day. We really need to have that relationship to build that continuity of care. So we're really focusing through this process to clean up our patients' panel sizes and make sure that those patients and those have relationships with their providers.
Great. And my next question is, how do you see that? What are the pieces of this that you think will provide the more affordable care most quickly?
Well, I think if community health centers have really never been, very few have looked inward and looked at and done a lot of data collection. So I think a lot of them, because they're so busy and overwhelmed, they're really trying to provide the best care possible with small resources. And so I think the best we can do to do a lot of data collection and do a lot of measurements so they can see where they're excelling, where they need support. With the new UDS reports that the health centers need to fill out, have 5 clinical areas that they need to focus on: diabetes, hypertension, HIV, one mental health, one dental issue. And so we really want to make sure that they're meeting different goals as they, perhaps screening is another one, that's another clinical measure that they need to measure. But we now have data to see how they're doing in those clinical areas, and we can now provide some best practice guidance on how they can do improvements.
What do you see as the next steps moving forward with the project?
Well, one next step is we're partnering with this urban service track to get opportunities for 22 graduate students in pharmacy, nursing, dentistry, and medicine to work in health centers throughout Connecticut. That's through our search program that's just kicking off this fall. And the thought is that once we get those students, those graduate students in the practices, we train the mentors and preceptors to make that a really enriching experience. Hopefully we can encourage more providers to go into primary care, which has been lacking recently. But also we can use some of these approaches and train the students to be cognizant of some of these issues so they can do some teaching upward and teach their preceptors and mentors on some of these concepts.
Great. Thank you very much.